Good afternoon, everybody. I'm pleased to welcome you to this year's Margaret and Theodore Marr Family Endowed Lectureship in Electrophysiology. And we are honored and privileged to have with us Dr. Koonlawee Nademanee, who is coming here all the way from Thailand to give us this lecture. There are people joining online, and for those in the room, if you have questions for Dr. Nademanee, you can go to the microphone at the end. I'll be moderating online questions from the computer there. And if you wish to speak while you're online, raise your hand, we'll unmute you, and then you can ask your question. With that, I'd like to introduce you to Dr. Koonlawee Nademanee. So Dr. Green has known him for over 30 years when he first visited us at the Ottawa Heart Institute, and then he's coming back after 30 years or so. I have known him for 22 years, been to his lab. We are privileged because he's one of those electrophysiologists and cardiologists and physicians who has made significant contributions and changed practice in electrophysiology. So Dr. Nademanee graduated from the Chulalongkorn University in Bangkok, Thailand, with a Bachelor of Science degree in 1971 and earned his medical degree from the university in 1973. Then he moved to the US, completed his internal medicine training, obtained American board certification, and then a cardiology fellowship at the West Los Angeles VA Medical Center and UCLA. And he also was certified in electrophysiology in 2005 and awarded an honorary doctorate in medicine from the Mahidol University. Dr. Nademanee has published over 200 original contributions in the field of cardiac arrhythmias and electrophysiology, pioneering critical advancements in this area. In 2023, he was named one of the world's top 2% scientist careers by Stanford. He was the first to recognize the importance of substrate, which he classified clinically as complex fractionated electrograms. And that improved our understanding of why some individuals maintain atrial fibrillation for long periods of time. And to this day is being evaluated in clinical trials to get suppression of atrial fibrillation. He was one of the first people, if not the first person to actually describe the Brugada syndrome. And this pertains to sudden death in Southeast Asia, and that is what brought it to his attention. And he, along with Dr. Anselwich, Dr. Wilde, closely worked together to develop treatments. And he was the first person to do epicardial ablations for patients with Brugada syndrome that had multiple shocks, which is really disturbing to patients. He was a tenured professor of medicine at the University of Colorado and the director of cardiology there. He was also tenured in the University of Southern California. He is currently a distinguished professor of medicine at Chulalongkorn University and director of the Pacific Rim Research and Heart Institute at Bumrungrad International Hospital. He serves on the editorial board of at least 10 journals, all of which are highest impact in cardiology, including Circulation, JACC, and so on and so forth. He's part of innumerable guideline committees and a leader in the field. With that brief introduction, I can go on for 2 days with this CV. I will invite Dr. Nademanee to come and talk to us about his life's work.
Thank you very much, Dr. Nair, for kind introduction. And good afternoon, ladies and gentlemen. But first, I would like to thank Ottawa Heart Institute for inviting me here. I'm very honored and humbled by this invitation, and very happy to share with you about our work that we have done for the past 3 decades. Also very grateful and very, very thankful to the Marr Foundation for support and sponsor my coming over here. Thank you very much. My task today is to talk about the J-Web syndrome advances. And this is my disclosure and this is my funding sources. But I want to go back to remind you that not so long ago, when you're looking at the sudden cardiac death in the young, and this is the paper written by Dr. Simon High, that the leading cause of sudden cardiac death at the time in the athlete was hypertrophic in 35 and younger. And coronary artery disease, obviously, when 35 and longer. Fast forward, now the leading cause of sudden cardiac death in the athlete, in the young, is sudden arrhythmic death syndrome or sudden unexplained death syndrome. Partly, maybe perhaps that people now recognize the hypertrophic and then treat it early. And it just so happened back in the end of Vietnam War, there was a syndrome called sudden unexplained death syndrome because of the Southeast Asian refugee coming to the United States, and they peculiar die at night. And they actually, the term at the time, the CDC coined the term sudden unexplained nocturnal death syndrome, SUN. But later on, they changed to SUS because of the 10 to 15% of the patient happened not during the sleep. And at the time, I get this involvement to investigate, because following the Vietnam War, there's a lot of the refugee going to Thailand and have a sudden unexplained death syndrome at night like this. So we found that the majority of them had this a lot of nocturnal ventricular fibrillation and have the curved Thai ECG pattern known as Bumrungrad syndrome. And Bumrungrad syndrome was described in 1992. We published it in 1997. I was really the slow writer. The other important thing is we also learned at the time that having ventricular fibrillation doesn't mean you have to die. And this is a very key, is a case report, but it's very graphic, that you can see that the patient have ventricular fibrillation over, I don't know, I forgot, I should know that it's over 1 minute and then didn't die, okay? And for the fellow, when you program just remember they said, no, don't program to shock the patient too soon. Okay, but now we accept that the sudden unexplained death syndrome, the majority of this is basically the J-Web syndrome, especially in Southeast Asia. 92% is either Bumrungrad syndrome that have the pattern of the Bumrungrad curved Thai like this, or early repolarization syndrome that have been propagated by Michel Hezekiah and then the group from Norway. Only 3% and maybe perhaps 5% was related to CPVT, short QT, or in the idiopathic ventricular fibrillation. And I'm sure soon idiopathic VF will be even smaller because we will find out what's wrong with that, you know, like a filament C and all that kind of thing. What I'm going to talk to you, the touch base about the mechanism of the J-wave and characteristic of pathology and the genetic and a lot of time devoted into the ablation of the syndrome. As I mentioned, J-wave syndrome consists of Bumrungrad and early lipo. However, 20–30%, especially in Southeast Asia, the two syndromes combine. In other words, just like this patient that you can see here, that they have a Bumrungrad ECG pattern in right precordial lead, and then lateral J-wave augmentation in the lateral lead and also inferior lead. This is the deadly combination. You have, this patient have a lot of recurrent episodes of ventricular fibrillation, as you can see here. Now, during the first 2 decades of the J-wave syndrome, the only 2 treatments, ICD and quinidine, both have limitation. ICD does not prevent recurrent VF. And what happens if you keep having recurrent? Quinidine has been known that it is effective, but unfortunately not available in most parts of the world. And even now, in the US, we have a tough time to get it. And the quinidine is known to have a long-term side effect. So, and also the first 2 decades, the pathophysiologic mechanism of the J-wave syndrome is dominated, especially for the Bucata syndrome, that had the family of occurrence and very common in about 1 to 2% of 2000 in general, is repolarization abnormality based on the wonderful work of Charlie Ancelovich and his colleague Young in the wedge preparation. But I just want to remind you that wedge preparation is not human heart. And the premise is that because in the phase 1 of repolarization, a transient outward potassium current, there's a discrepancy between the outward current between epicardium and epicardium. Sometimes you have a notch and dome apparent, or sometimes you have a short action potential because you lost the dome, and that creates the SC elevation and inverted T wave. That had been dominated for 2 decades. And in 2005, the Amsterdam group proposed that, well, how about the late depolarization? If you have a late activation in the epicardium, then you can have the gradient different, and that it can cause SC elevation too. And that had been debated for some time. We fortunately kind of threw the argument to one side, because when we had the opportunity to perform mapping of a patient who have recurrent VF from Bucata syndrome. And lo and behold, when we put the catheter into the epicardium and we recorded fractionated signal, low voltage, and then when we ablate this site, we normalize the Bucata ECG pattern, as you can see here, and prevent recurrent VF episode. This case is over 10 years now, the one that I show you. And also importantly, the location of this fractionated signal, low voltage, long potential, coinciding with the Bucata kind of pattern in the unipolar here, is only in the epicardium. The endocardium side of this area did not have any fractionated signal. So it's just localized in the epicardium. So we published it in initially 9 patients that this area exclusively over anterior RVOT epicardium. And when we ablated, it's very effective in preventing recurrent VF. But at the time, we were wrong because we didn't have Ashmarine testing, because at the time it's a protocol, the IRB wouldn't approve it. Later on, we learned more, and I will share the data. The only thing that is not necessarily exclusive at the RVOT epicardium. The question then arises, people ask me at the time that what really underlying the cause of the fractionated signal. And the wonderful work that's done from the Amsterdam Medical Center by Jack DeBacker. And they're showing in the infarct area of fibrosis, a bunch of the bundle that have the collagen deposit, just like they're shown in here, that if you stimulate from the side A into this bundle, and then you record the bipolar here, you will record the zigzagging signal of the conduction. And since this is asynchronous, then you record all the potential throughout the transmission of the impulse. And that's causing the fractionated electrogram like this. So, but the patient, let me go back to the chart. But the patient, all the patient imaging study, MRI, never show any fibrosis, never show any scar. Why is it happen? And then Dr. Ancelovich did in a wedge preparation, said, well, he sees the same thing in a wedge preparation and published in JACC in 2014, 3 years after we published it. But I want you to notice that the the signal is not exactly the same thing. And then he said that some of this is causing the biphase to re-entry. Now, if this is the case, you will see a lot of variability in the electrogram. I can show you, I didn't show you the recording that you can do this for 2-3 minutes, and the signal would always the same in our patient. And this is recording through the epicardium. Fortunately, we had a patient that we can take into the OR, and then in collaboration with St. George Hospital in London, UK, with Mary Shepherd and Elizabeth Bayer, to look in their necropsy cases. We have patients that we could not gain access into the pericardium, only just because of adhesion or that somebody patient needs lead extraction. We will then give us a case to do open thoracotomy mapping. And this is the CT grid showing the area of the mapping on the RVOT. And you can see here that in the size 8 and size 9, and this area you see fractionated signal, as you can see here. And this is site that we did the biopsy. And the biopsy show, this is the Pico series stain to stain collagen. Purple represent collagen. And you see that very thick epicardial fibrosis. We have done now over 10 cases. This is combined with the Dr. Nogami in Japan. All have epicardial fibrosis, very thick like that. And also had interstitial fibrosis with focal replacement. So when you see that, then, okay, that it fits with the Charlie-Barker theory about the zigzagging conduction and so on. And then this patient, we did open heart ablation with the RF, and you can see here, post-asthmaline, that no longer have a Bucata ECG pattern, and he did very well. Now, this is also another patient that we did the mapping, but I want you to notice that in this area, up there, number 3, you can see the signal, the electrogram is normal before asthmaline. But after asthmaline, you can see here in the lower signal. You can see this is normal before asthmaline, and after asthmaline, you see the fractionated. And you see the unipolar look like a monophasic. And then when you see like that, I was touched by Ruben Cornell. When you see like that, that means that no excitation because that is record from the intercellular. And when you do biopsy, you get, I'm sorry, the biopsy, you see the collagen. This is Mason trichome stain that show the collagen. What this slide shows very clearly, that even though you have subtle fibrosis, by itself, sometimes it doesn't show fractionated electrogram. You need reduction of sodium current. In this case, asthmaline unmasked it. That's why the asthmaline unmasked the Bucata pattern. We published it in Heart Rhythm. But also it can be anything. It could be fever, could be any condition that genetic SCN5A and so on. And this is just to show you that when you have the you can have the mechanism of the fibrosis that can cause no excitation, zigzagging conduction, and it show you example. This patient is also in the open heart. And during, you see the electrogram here, this one you have the fractionated signal, zigzagging, and then here you have the third component, no excitation. Same thing with in the proximal. This and you see the unipolar looking like a Bucata. So this slide alone and what I show you, there's no question that all the conduction abnormality from the zigzag slow conduction, reduced electrical coupling, and then current to load mismatch. Show that in here to represent. And this is a group from the ECGI as a group that when you compare baseline asthmaline widen the area of the lead activation or lead zone, coinciding with increase in SC elevation and low voltage. How about early repolarization? I want to do it quickly for the interest of time. This is typical type of the pathologic augmentation. And the prevalence is about 2 to 3%. And just like a Buccara syndrome, you have a sudden cardiac death, high incident. And this is the early repolarization can be caused by the enhanced phase 1 repolarization. This is a paper that Michelle and we published it in there. This patient didn't have the repolarization, but you can see here the bump of the augmentation of the repolarization of the unipolar coinciding with the, in this area, coinciding with the early repo. But on the other hand, we have this case that this is the Thai patient that have the early repolarization that we could not gain an access into the epicardium. And we took the patient into to the OR, and this is the EKG. And I invite Ruben Coronel and Baskan to come to Thailand to using that machine to do the open heart mapping with the multiple electrode. And you can see here that this patient, you see that the unipolar epicardial augmentation doesn't coincide with the J-wave, okay? And then we took the patient to the lab. He had multiple episodes. This is the Chulalongkorn Hospital, Marr University, and then the open heart. And then we measure depolarization and early repolarization. And what we found that in the area of fibrosis, in this area, because we did a biopsy, I'll show you later on, this is local activation, this is J-wave amplitude. The area of the slow conduction or deceleration of the conduction is correlated with the J-wave amplitude. So this J-wave amplitude of this patient caused by the delayed conduction, and you can see here that from the plot, it's a nice linear curve. And then Basque have the Amsterdam group have the way to develop this. This is the picocellular stain to show the fibrosis in this patient, and then have the multiple sequential, multiple bundle. And this is the 3-dimension of that. So again, we would believe that the early repolarization had a component of the delay activation and then conduction abnormality as well. Now I'm going to go to the genetic a little bit of the Buccara syndrome. This SCN5A was published in Nature. The first one that showed that when you have a reduction in SCN5A and then the gene that governs the sodium channel development, as you can see here, then you develop, you have Buccara syndrome. This is the same gene that causes long QT3. But that a different is long QT3 is gain of function, whereas the Buccara syndrome is missense mutation or nonsense mutation, and then basically the loss of sodium current. And in general for the audience, it's when you have loss of the function of the SCN5A, then you markedly reduce sodium current. And then initially, a lot of people tend to try to develop the Buccara syndrome like a long QT syndrome to develop a BRS1 to BRSA. But the reality struck later on that when they found out that some of the mutations that were coded might be the cause of the Buccara syndrome turned out not to be the case. The only one that it definitely developed and believe that it truly underlying so far is the SCN5A, and it had to be pathogenic SCN5A as well. In fact, the wonderful work by the European and led by Connie Bessina, and it did show that in most of the genetic of Buccara syndrome is oligogenic, polygenic. What does it mean? It means that when you have the monogenic, it's just like Mendelian, like when you have the hemophiliac, that's monogenic, and then it's causing very obvious. For Bucata syndrome, it's very rare. There's some SCN5A that could be monogenic. But most of the time, it defines 2 or 3 variants. And that usually is the SCN10A, and then ERK gene, and then also SCN5A. It combine the 3, then you have a phenotype. And the higher the score, more than 4 alleles, then the higher the chance that you're going to have phenotype. And the SCN5A also, I want to tell you that SCN5A that govern the sodium channel here also linked with the cytoskeleton. This is slide that I borrowed from Jeff Tobin. And some of the abnormality in the dystrophin or entropin or any cytoskeletal gene can also affect sodium current and Na 1.5, just like this one. That this is easier to look at the version. And then there's a report of PK2, practically that have a combined Bucata and arrhythmogenic right ventricular hypertrophy that's been widely published. So we also, just to let you know that there's a recent publication that from the Paponi group that they found the autoantibody in the majority of the Bucata syndrome patient, 90%, to have this antibody toward the SAM 1.5. And that remains to be seen. That we have to further investigate. But the point is that when you're dealing with Bucata syndrome, you have a subepicardial myopathy and epicardium fibrosis. And then you have to have a reduction in sodium current, whatever the cause it is. In Thailand, we do the whole genome sequencing. Just quickly, we found that certain SCN5A that have intermediate can cause the, when you combine with some of the gene variant like a SCN10A will cause the Bucata syndrome. We also, in the intron of RE5 here, the paper now being in press in circulation, that the regulator of the sodium channel can cause the Bucata syndrome. And this one also, we have 2 patients in this group that have combined Bucata and early reported ablation. So that's something that's exciting that we have to explore further. And so the genetic of Bucata is very complex, but we will learn more. Quickly, how do I do with the time? You say, okay? So okay. I'm not going to depend much about Bucata syndrome risk stratification, because the only thing really most important, you could ask a question whether or not the patient is symptomatic or asymptomatic. Okay, basically, symptomatic have a really bad prognosis. I'm talking about our hospital cardiac arrest, documented arrhythmogenic, syncope, VF, and so on. Those patients need to be treated, no question, because the risk of dying is very high. And in the past, it's only ICD. Asymptomatic, there's a good paper that recently published by Dr. Gator group that about 0.4%. Our job is how could, now we have a treatment. How could we find the 0.4%? In the past 20 years, people will develop all kinds of the risk variable as you list here. I'm not going to read it to you. There's some pro and con, some of the value of this variable. So people develop the risk score. I'm just showing to you that there are Sierra risk score, Shanghai risk score, there are all kinds of risk score. They're not perfect. And the reason we have to have a debate, because if you have a patient asymptomatic, you don't want to just go ahead and put ICD to everybody, because ICD in the young also associated with risk. So it's very important for us to find what it would be the best risk score system that we can use. The reason this one is also exciting, they were published recently, I think beginning of this year or the end of last year, that have using all kinds of risk score that I list here. You don't have to read it. And they combine it and then go to the meta-analysis and sophisticate the statistical function. And they found that it could predict it better than other risk score. But eventually, what we need to do to find what it would be the highest specific to identify the 0.4% of asymptomatic patient that would need treatment to prevent the recurrence of VF. And that I don't think we have it yet. So the European guidelines said that asymptomatic patient, it may be considered the PES, program stimulation, and ICD implantation may be considered if it inducible with 2 extra stimuli or 1 stimuli. And this seems to be consistent with Japanese data and also a couple of other data from Europe. Ablations, since we published it, that have been used worldwide, and then a number of centers are now doing, and then found the same result. The largest one was from Paponi group, but you can notice that a lot of his patients is no spontaneous, and a lot of those are asymptomatic patients that they were doing. But nevertheless, catheter ablation has been added on to the armamentarium of the JWEB syndrome now. But we have a knowledge, one gap. We don't have a long-term outcome. We don't have a large-scale clinical trial, and we have to answer the question: can it be standalone treatment? So we report this last year of the Bravo registry, just basically just to find out how the multi-center long-term outcome of substrate ablation, and the inclusion and exclusion criteria is very simple, that the patient have to come and follow. And this is from 3 continents, from Asia and Japan, China, Europe, and America. We studied 159 patients. Almost 80% had survival of cardiac arrest. 34%, 21% have syncope, and a majority has a spontaneous Bucata pattern, and then 27% had combined syndrome. And the majority of the patients are Asian. And this slide shows the patient from the index event that put ICD discharged. You can see that the majority of the patient would have the ICD discharged. The most important thing in this slide that I want you to notice is that when the patient have the shock or recurrent VF episode after the ICD during the first year, the likelihood that they're going to have more than multiple shock is very high. You can see here that ranging from 1 to 4 shock to 5 to 9, 10 to 20, and more than 20. So if you have a patient have recurrent VF, then that means you should consider to do something. This is the results of the ablation. On the left is before ablation. We arrange into the group like 1 to 4 shock before the ablation, 5 to 6, 10 to 20, and greater than 20. And you can see here only 6 patients that still have some episode, and very few when they used to more than 20 like that. And the patient did well; they didn't want to have a redo. And the distribution of the VF substrate, 100% was in the RVOT and RV. 20%, 29%, almost 30% in the inferior wall. So my former slide that I was told from our first publication that exclusively in the RVOT is not correct. That also have software, and we have 2% in the LV, posterolateral too. So that's what I meant. But it's still in epicardium, a majority in the RV. And the single variable that predicted the success of the ablation is the absence of the Bucata ICG pattern, especially after the Ashmally testing, just like you can see here. In this patient that had no pattern left, only 1 patient, and that patient had a combined Bucata and early lipo. So based on the Bravo study, we believe that normalization of the Bukhara ECG pattern after ablation without concomitant early lipo, at least on this data, prevent VF in all patients. And it had connotation for the future. And if more clinical trial confirm this, then we might be considered to select some of the patients that be treated without ICD. And that this is a group that I was talking. It's a well, no, let me not I jumped. Also the ablation now it become a class 2A for the recurrent ICD, it's symptomatic. And now I'm talking about the asymptomatic patient that I showed before. I add this one on my own. The catheter ablation in a symptomatic patient from the European guideline that said, no, you shouldn't be doing it. But how about if you induce this? Instead of putting the defibrillator, can it be treated with the ablation? So should we do an ablation in a symptomatic patient? No, as a European guideline. But if it's inducible by 2 extra stimuli, it's cut 2A, 2B, you put an ICD. So what you want to do, ICD, or you want to do ablation? If we do an ablation without concomitant, then we don't have to put an ICD. And this is what I plan to do, a randomization in the future. Now, the last part is I'm going to talk about the early lipo ablation. In a way, early depolarization is a misnomer because what I'm just about to tell you that the majority of our patients had a depolarization abnormality. We published in 2019. The aim of the study is to define VF trigger and subset of early lipo. And we want to determine, because this is based on our experience from the Bukhara and the syndrome that we have a subset. And since it makes sense, and you can infer that since 20 to 30% of the patients have combined syndrome, so they may be the same disease. So it's nice to go and export to do a mapping. And that's what we did. And we did 52 patients, again, combined with the Bordeaux group, and then Dr. Nogami group, and then from UK, and then Dr. Rajabe from UK. And the location of the J point is in 36% in the inferior lateral and 58% in the inferior wall only. And the majority of our patients all are asymptomatic, but the majority of them about the sun cardiac death, and then have the multiple ICD discharge. Quinidine failure, 82%. Now, I don't want you to think that the quinidine is not good for this, but the reason that we have high quinidine failure because they failed, that's why they refer to us to do a mapping and ablation to begin with. And this is a good one example. This is a patient, 21-year-old, that his twin died suddenly 3 years before, and then he had an ICD. You can see here the PVC here. He had the inferior wall early lipo, but this the PVC, this is V1 coming from the left side, did not trigger VF, but this PVC coming from the right side causing VF. So when you do a VF trigger, when you see PVC, it doesn't mean that's a smoking gun. You have to, smoking gun is when you see the PVC that trigger VF just like this. And when we record that this side is coming from the right Purkinje system, and you can see here, you see it's a more tiny Purkinje. I don't know. You probably can see that like that somewhere here. That's it. And then and when we ablated, the trigger disappeared. But we went ahead and mapped the epicardium of this patient. And you can see here in the RVOT, you see some fractionated signal, but worst one is in the inferior wall. And then when we ablated this patient did very well. This patient, I just go quickly. This patient, we had the early lipo, had VF, and then sometimes the early lipo in the both in the lateral and inferior wall disappear when after the VF. Sometimes it happened when we map the whole the whole heart. There's no abnormality in epicardium or depolarization, we have to ablate the Purkinje system in this patient. So based on this study, we of 52 patients, we can map 51 patients in detail. We divided the early lipo group into two groups. One is abnormal, that group 1 had abnormal depolarization abnormality. How do I know that they have an abnormal depolarization abnormality? Because they record fractionated signal like this. Okay. And then group 1, we divided into group 1A that had a combined syndrome, Bugada and early lipo. And group 2, the only pure early lipo without Bugada. And this patient, we know that didn't have Bugada because they have negative asthmaline. And then we have group 2, only 11 patients, small minority of this study, no abnormal depolarization. We couldn't find fractionated signal anywhere. And this is one of example. I want to show you that the patient have the early lipo in the inferior wall. But if you look at this thing, in this EKG here, might be some Bugada. This patient had a combined syndrome after asthmaline. And when we did the study, we can record the fractionated signal here in the inferior wall. This ECGI show the composite map during VF. The shade area show rotational activity, and the number show how many rotation is. And then the hexagon show the VF focal activity, and that is in the RVOT and also in the inferior wall. And you can see the associated fractionated signal. And look at the J-wave augmentation in this unipolar. And in the RVOT also we record the fractionated signal, again unipolar. So we know this is the substrate. And then if you see the movie, you can see here the rotation and focal activity in RVOT and inferior wall. It looks really nice. And after ablation, we normalize the pattern of the Bugada pattern, and this is after asthmaline. And then you can see, you see slight acceleration here in the inferior lead, but it's not that marked as it before. And this is kind of complex slide, but you can see the area that we identify at the substrate that you can see fractionated signal. So the fractionated signal represent depolarization abnormality coincided with the VF driver and focal activity and rotational activity. This is another example, beautiful case of PVC in the re-entry here, and this VF showing the from this area thicker VF. So this is not coming from the Purkinje. We just got lucky to have this during. That was the advantage of having ECGI, you know, to see it. And then you can see here the very nice rotation, no question about that. But when we map the patient and to show the composite, the rotational activity is not just localized there, it's also in other places, and it correlates with the fractionated signal. So we have to ablate them all to be successful. And so this is summary about where the location of the substrate and the VF driver. A bit different than the pure Bugada syndrome. 100% of the patient in a group 1 depolarization abnormality still have the RVOT and RV body epicardial substrate. But looking at the inferior wall, remember the Bugada had only 30%. This is almost 90%, okay? And in the inferior wall. And we have the 24% and 36% in the LV as well. So this is, but the ablation, we don't have to ablate all the, in this area in the LV that much. We have to ablate some patients. Well, at group 2, you see that the VF substrate, the driver is not in the LV that much, 40%, but 100% is in the septum. That represented the Purkinje kind of the re-entry that causing it VF. I'm going to quickly to go that in group 1, we have 40 patients in group 1, underwent 37 and then underwent electroanatomical mapping, and then we did the ablation of this patient. we didn't do an ablation in 4 patients. And then in group 2, we didn't do ablation in 5. We did ablation in 6, and all had the left Purkinje system for VF trigger. This slide complex, but I just want you to pay attention to this column. No VF in baseline. In baseline, we have all the patients had VF episode before. The majority of them had more than 5 episodes at least before ablation. After ablation, first session, 67% we were successful. But when we repeat the second ablation, we achieved 91% success, which is, we were happy with that. Hopefully we could do better. And the mean ablation is 1.4 times. So in summary, the early repolarization had 2 phenotypes. One with the fractionated signal represent depolarization abnormality, which coincide with the focal activity and VF driver. And the second phenotype is a patient who did not have any depolarization abnormality, but perhaps they have the truly repolarization abnormality, and that need to be further investigated. And the majority of the early repolarization, if we get this ablation successful in the target site, they did very well, and it's very safe. And I just want to show you that in the future, I think catheter ablation will become a primary treatment modality for symptomatic JVAP syndrome. As Kolopus would agree, but he wants to have the catheter ablation too. Ablation catheter in his hand too. Thank you very much for your attention.
Can you come here or we pass you the mic?
Thank you, Wee. That was spectacular. A couple of questions, but let me start with the idea of right ventricular fibrosis and scar being one of the dominant features of this. If we take patients with PKP2 or desmoid or even DSP who have predominantly right ventricular scar, who present with VF rather than VT, because we know that does occur. If you give them asthma, what would happen to their ECG? Would it look like Brugada? Would they get ST elevation? And I have other questions to follow up.
It has the one that they report, it has a beautiful Brugada ECG pattern. And if the patient had a ARVC trait, we have to be very careful about giving the sodium channel blockade challenge too. So, and that patient had a very nice pattern. And as you know, there have been reports from the Domenico group from Italy, from the Venetian area, that a lot of their patients have the ARVC and they had the Brugada ECG pattern. So that it's been well known.
Is there any particular genotype associated with this?
That one from Domenico, they didn't report. I'm not aware about. I don't think they report SCN5A or any dysprotrophin or PKB2. You know, I tell you what, I can show you this slide. That what we propose here, that you can have the range now. That in the patient of idiopathic, we have the histopathology might be very subtle subepicardial fibrosis, and we have some of the. Michelle and I would wrote a couple of cases, but you don't see any EKG change. It's not severe enough. And then you have a Brugada syndrome that have the RV epicardial fibrosis, and then we can have a marked changes in early lipo, and then you have the full arrhythmogenic ARVC in this group. we come over.
Thank you so much for the fantastic talk. So just have two questions.
Sure.
First, is the fibrosis in Uganda associated with the sodium channel mutation, or it is an independent factor or mechanism?
Great question. To be honest, I have to answer that. I don't know. But there have been data to show that if you have chronic reduction of the sodium current or development of the missense of mutation, you may develop fibrosis. Several people try to develop the animal model now to try to do that, to answer that question. There was one, I think, that was written there, but it's not sure yet. The other possibility is that some of these patients with probably combined with their genetic variant that make it prone to sensitive to, let's say, viral infection, and it had changes because there are some endocardial biopsy done from the Italy. I didn't show the data that show the information and things like that. So it could be multifactorial, but your question is very, very good because there are a lot of people believe that might be the case, that when you have the variant and then subtle. The problem is like in Thailand, SCN5A, pathogenic SCN5A mutation is only 6-7%. The European group has about 20%, much higher.
Thank you. Another question, sorry. So how frequent is the sinoatrial node dysfunction in this Brugada syndrome?
In our group, almost none. The sinoatrial dysfunction is more in the pediatric group, children group, and that is really bad. So the children or some of these patients, the atria sometimes didn't even contract, didn't even have any, and then to treat them with a pacemaker even really difficult. Those more in the pediatric group. Well, in pediatric group have atrial arrhythmia and also conduction defect and atrial dysfunction. That usually always associated with positive SCN5A, but did not have a lot of VF.
I had two questions. One, we talked about EP study in asymptomatic patients. What's your approach and what specifically asymptomatic spontaneous type 1?
To be honest, we did a study. We didn't really publish it. Randomized funded Medtronic. We did a full EP study in the patient, and we have a nice long term. We published part of this. In the device group, we did not have any patient have VF. Okay, so it's 0. In the non-device, we didn't put anything in that to death. One have EP positive, one have EP negative. And based on that, I didn't really care about the EP study. So I didn't do the EP study for some time until I saw the Japanese data when I went to give talks, and then they share me. Japanese is very meticulous, and they have the whole island that they combine. And the data is very convincing. If you induce by a single, or by a double, it means something. And that had been confirmed by the, I forgot whom, I can get back to from the European study. That's why you come up with this guideline, that if you positive single, double or lower, or single, then you might either put ILR or you might put an ICD.
triggers for VF in terms of ablation when you're looking at your area 6 and area 5. Is around the area where you may be.
So far, we didn't have any problem where the patient that I didn't show you because the limit of time. We try to map for early lipo the type 2 phenotype. We look in the Purkinje system, and one of the tricks that you can look is that usually the bad Purkinje that contribute to VF, the trigger usually have also fractionated abnormal signal. Okay, and those then I do induction, VF induction, and you can see here that the abnormal fractionated rotational activity is right there. So then you can feel comfortable to ablate that. And usually, in just like when you ablate Purkinje system, that usually doesn't cause any problem with the LAD or anything like that because it's endocardium. Okay, I go back. Which one?
One with the two DBCs, you said the left, the one.
Oh, I see. Yeah.
That failed to initiate, but the right ventricular one.
Yeah.
Yeah, it's the one before that one. So the left ventricular one actually causes a pause.
Yes.
And the right ventricular one is post-pause.
Right.
So I'm not sure that the left ventricular one wasn't a critical factor in doing this because often the pause is an issue. So just wondering what your thoughts on that.
It's reasonable, but you can see here this one really tickle it. You're right. It may be long short cycle length that causing that. But it by itself, I wouldn't call that as a VF trigger because the VF trigger truly is from the right side. And when we ablate it, now, I cannot say because we ablated, the patient have no more VF because we did also ablate the substrate. So the point is very valid, but this PVC was when we ablated, patients seem to be doing fine. But it's very, very astute. Yeah.
No other questions, then we'd like to thank Dr. Nademanee for coming all the way to Ottawa. This is the second trip. He was here in 1991 when there was only one cath lab, and it's with Dr. Bean Senior and Dr. Bean. And now he has come and I took him around the hospital and done his transformation. So, and Dr. Bean's Senior's son is now the CEO, Dr. Rob Bean. So 30 years later, he has come to us. So thank you so much for coming.
Yeah, that's right, because I had such a fond memory. When I came to see Dr. Green at the time, it's a dawn of ablation. We were still, a lot of people still do a surgical ablation of the surgical resection of the pathway, but that at the beginning of RF of the ablation. And we talked last night that if you tell me that, told me at the time that I'm going to do things like this 30 years from now, I would never believe it. Thank you very much for your attention and for the honor.